Miss Wells is a 28-year-old African-American woman with a history of asthma, diagnosed at the age of 2.5 years, with no prior intubation but 5 hospitalizations for her asthma, last at the age of 16. She is also a former marijuana smoker of 5 to 6 years, stopped at the age of 21 years. She denies current use of tobacco, alcohol, and illicit drugs. Today, Ms. Wells presented to the clinic with complaints of shortness of breath and wheezing following a near asthma attack 2 days ago at her cousin's house after an exposure to cats, which triggered her asthma symptoms. At the time of the attack, she noted that her wheezes were 6 out of 10 in severity and her shortness of breath was 8 out of 10, lasted 5 minutes, for which she used her albuterol inhaler, decreasing her symptoms but not resolving them completely. Since that incident, she notes that she has had 10 episodes of wheezing and shortness of breath approximately every 4 hours, and her last episode was this morning before coming to the clinic. She also notes that her current symptoms seems to be worsened by lying flat and movements, are accompanied by a non-productive cough, and awakens her twice per night. Currently, she states that her breathing is normal, but she's concerned that her symptoms are beginning to interfere with her daily activities and that her albuterol inhaler seems to be less effective. Ms. Wells maintains eye contact throughout the interview and examination. She is alert and oriented, sitting upright on the exam table and in no acute distress. Chest expansion is symmetrical with respiration, normal fremitus, symmetrical bilaterally, chest resonant to percussions, no dullness, bilateral expiratory wheezes in posterior lower lobes. Also bilateral muffled words with notable expiratory wheezes in posterior lower lobes. No crackles. In office spirometry shows FVC is 3.9 milliliter and FEV1 to FVC ratio is 80.56%. SpO2 is 97%. Based on this information, pending further tests, I would initially diagnose Ms. Wells with moderate to severe persistent asthma with acute exacerbation. Since Ms. Wells' wheezing and shortness of breath happens more frequently, she should also be educated to record her detailed attacks accurately. She should also be educated on how to use the incentive spirometer and monitor her peak flow values daily. Since Ms. Wells is not aware of any environmental exposures or irritants at her job or home, I would refer her to see an allergist for allergy testing and to identify and minimize known asthma triggers by avoiding allergens and irritants. Symptoms prevention is very important. I would also refer her to see a pulmonologist for a more thorough assessment of her lungs, such as the pulmonary function test. Furthermore, her current albuterol inhaler needs to be reviewed, as she stated that it seems to be less effective. In this case, probably a low to medium dose of inhaled corticosteroid or the ICS can be added to her short-acting bronchodilator. Thank you.